Today, I am very excited to introduce Dr. Whitney Trotter Ross. So, a little bit of a backstory. I actually first came across Dr. Ross's work while gathering information for my own dissertation research. And I was immediately drawn to the pragmatic, patient centered approach of the PEEPS study. I also noticed that we shared a mutual connection with Dr. Anna Bauman, who was so nice to connect us. And then after talking with Dr. Ross, I learned that another strength of the PEEP study was the iterative adaptation process. And I knew that this presentation would be really interesting, especially for this particular work group. So Dr. Whitney Trotter Ross is an assistant professor of OBGYN at WashU Medicine and minimally invasive gynecologic surgeon. She completed her MD at East Tennessee State University, her OBGYN residency and Masters of Science in Clinical Investigation with a concentration in dissemination and implementation at WashU Medicine, and her master's fellowship at Penn State Health. Her research focuses on mechanisms underlying endometriosis, associated pain, non-invasive diagnostics, and patient-driven integrative behavioral interventions. Clinically, she specializes in the surgical management of endometriosis and complex benign pathology. So I will hand it over to you, Dr. Ross, and feel free to use the chat to ask any questions or comments. We will be monitoring it.
Thanks so much, Kara, and thank y'all so much for having me. Let's see, are you seeing the correct, or are you seeing presenter view or the other view?
Other view.
Okay, so we're good.
Oh no, sorry, presenter view.
Okay, so swap.
Yes.
Now are we good? Okay, perfect. So, like I said, thank you so much for being here. It's always so fun to think about what I'm doing, like more from the implementation science lens, as well as kind of all I learned from Anna and so many of the WashU D&I crew over the course of the MSCI. I have a couple of disclosures, none relative to this, and I am super thankful to the different agencies that have funded this work and made it possible. So the objectives of the talk are to define the problem of endometriosis, introduce the PEEPS program, and then discuss the iterative adaptation process we've been using, and then some of the prelim PEEPS feasibility trial outcomes, and talk a little bit about next steps. So kind of zooming out, what is endometriosis? So it affects 10 to 15% of reproductive age women or anybody who's menstruating. It's when endometrium-like tissue or the lining of the uterus grows outside the uterus. This is hemosiderin and eosinophil stains, like what you might see looking at endometriosis lesions underneath a microscope. And while the lesions a lot of times don't look super impressive, it can cause a very wide range of symptoms. So dysmenorrhea is painful periods, and this affects about 80% of people that have endometriosis. Then it causes other types of non-menstrual pelvic pain, and then is very associated with anxiety, depression, PTSD, can contribute to infertility in about a quarter of people, and then can cause back pain, abdominal pain, hip pain, lots of different types of pain, and basically just can affect many domains of a person's function. As of about 2017, the treatment cost per year was $69.4 billion in excess health expenditures in the US alone. So it's also a fairly costly condition. Okay, I'm a surgeon, so I have to share some pictures of what I see on the clinical side of things. So this is what we might see looking into the pelvis. So this is kind of what a normal pelvis looks like. This is the uterus. Can you see my pointer? Okay, let me use a laser pointer. Can you see a pointer now? Okay, so this is the uterus here, fallopian tubes coming off to the side, and these are the ovaries, and here's space in what's called the cul-de-sac. That's a zoomed in view of a normal looking ovary, normal fallopian tube. And this is a normal cul-de-sac. So again, colon lives down here, uterus is up in this area, and this is what a normal pelvis looks like. When we're thinking about what the majority of people with endometriosis have, it's called superficial endometriosis, and it's very subtle. So that's what a lesion, we're talking on the scale of about 1 to 2 millimeters, can cause excruciating pain. This is another lesion, slightly bigger, probably about 3 millimeters. So very small contributing to lots of symptoms. In the more severe or deep infiltrating endometriosis, you can then, in this area, this is the normal part of the tube, and then this area in here is kind of a matted mess with lots of different types of lesions. And then this is more kind of fibrosis and scarring that we see in the more advanced endometriosis. The whole point of this is that we're talking about a condition that's very tiny that happens in women and menstruating people, and we don't have a diagnostic for it yet. So if you think about kind of the trajectory of symptoms, for a lot of people, it starts with first periods. So we're thinking somewhere between 11 to 13. Other people, it'll happen later in life, but for a lot of people, it starts right when they first start having periods or shortly thereafter. The cultural norm behind this and things that we've heard time and time again in focus groups and in different discussions is what girls and people are hearing are periods are supposed to hurt. It's all in your head. It's like, okay, this is all supposed to be normal. I guess I just suck it up. If I do want to get help, who do I go to see? When I go to see them, what will they say? Who will believe the symptoms? So that's kind of the first step. Then let's say somebody's like, okay, accepts that there's a problem. Then what does that look like? So the current diagnostic pathway is going for maybe a gynecology visit or a PCP visit, whatever the entry system is. Maybe that person thinks to order an ultrasound, perhaps start some birth control pills. That helps for some people, about 30% of people, that might be enough to get symptom control, at least initially. But for a lot of people, that doesn't cut it. So then they're in this cycle of more pills, more doctors, referrals, and maybe eventually they will land with surgery to get a diagnosis, which is what's required for about 80% of people to actually get a diagnosis of endometriosis definitively. If we're looking at kind of range of how long this process takes, from symptoms to access to healthcare or like entry into the healthcare system, on average is between 2 to 5 years, depending on age group. Shorter for younger people, can be longer for people kind of 30 and 40 and up. And then once into the healthcare system, that can actually be another 4 to 7 years between like starting this process of trying to get a diagnosis to actually definitively getting a diagnosis. So on average, that's about 10 years, give or take, from symptom onset to actually getting a diagnosis. So to kind of recap, affects about 10% of the female population, diagnostic delay ranging from 6 to 14 years. During that time, people experience tremendous suffering. The average is about 6.3 hours of lost workplace productivity on average per week, and then about 4.9 hours of lost household productivity per week. So during this time, there's really a huge opportunity for healthcare trauma and suffering that then by the time people do reach care, there's a lot of baggage from this whole diagnostic process. In terms of thinking about treatment, most of our medications are off-label. A lot of them kind of work in small degrees, but there isn't any type of surgery that can cure it like reliably for people. Kind of looking at the different recurrence and need for reoperation rates ranges from 50% if somebody is maintaining the like uterus and ovaries to 5% if someone definitively goes through surgical menopause. And kind of like we talked about before, so symptoms are affecting many different domains of function. So for a lot of people, their care team would look like having a gynecologist, a primary care doctor, a gastroenterologist, perhaps a urologist, definitely a physical therapist, likely mental health, ideally pain psychology. So it's a pretty complex care team that's needed for a lot of people living with endometriosis. So in terms of kind of over my fellowship, I kept hearing this story over and over again of how healthcare just wasn't working. So we did some focus groups to understand the problem more in terms of healthcare experiences, what people's needs and preferences were as they sought care for chronic pelvic pain. We conducted 6 focus groups between 2019 and 2020. I was fortunate to get to work with a trauma psychologist through this process and learn a lot about study design and how kind of to think about things. I didn't yet know about the field of D&I, so there was no framework. We just asked questions that seemed relevant at the time. And we kind of came up with these primary themes and identified that people living with chronic pelvic pain, whether or not they had a history of trauma, experience dismissal by individual clinicians and the healthcare system as a whole. that clinicians in the healthcare system play a key role in women's coping, either positive or negative, with traumatic experiences within healthcare, outside of healthcare, and with pelvic pain. It's kind of this whole experience of trauma and pelvic pain really intertwines. And then the participants in this group had really great recommendations for concrete and feasible ways to improve the clinical space in healthcare delivery. And something we heard kind of over and over the course of the focus groups was, hey, can we just like do more of these focus groups? Can we just have these more structured so we can get together and talk to other people and experience this peer support in this facilitated way? So these were some of my favorite, I guess, or some of the most kind of poignant quotes that participants shared. It's just healthcare as a system. It fails women like us all the time. How am I going to make them believe me this time and get farther than I was before? Because that's all I want this time. Years and years and years and years of going to doctors and saying there's something going on, there's something wrong. Years and years and years and years of saying it's in my head, prescribing, Prozac, Wellbutrin, and just about everything. It was always that I was crazy, that it starts in my head. And I understand that it is part in my head. There's a connection there, but it's also real. The pain is real. So we were kind of thinking about, so this is kind of starting to set the stage of what PEEPS would eventually become. And then kind of expanding a little bit from kind of focus groups in a very kind of niche patient population at a tertiary referral center. This was a study done by Elise, who's now a medical student. And she went to social media and some of the different endometriosis support groups to really understand the kind of care-seeking delay and the healthcare-related delay, and really found that people across the reproductive age spectrum, so by the age of 24, people had already experienced a 7 or 8 year delay in some cases, which was really heartbreaking. And then kind of experiences of dismissal, sexism, lots of really negative experiences are contributing. And then kind of fun fact in terms of social media studies for people with endometriosis, these English groups are actually capturing people from around the globe. So we're able to kind of get a little bit, all those small responses from other countries and kind of understand that it's not a US problem. It's not just a Europe problem. This is really across the globe as people are experiencing this problem. So in terms of kind of thinking about the different areas to address and kind of my kind of 3 areas of the problem that we've been seeking to tackle is really the care-seeking delay, the healthcare-related delay, and then healthcare delivery. So PEEPS really focused kind of on that end of healthcare has not worked well. How do we now kind of provide care that meets the needs of patients who have experienced so much hurt, both in life and through inadequate care? So now I'll talk a bit about the process of developing PEEPS. This is a really heartbreaking statistic. So this is a slide of conditions that have a similar or lower estimated prevalence to endometriosis and how much NIH funding goes to it per year. So for endometriosis, 10% of the population, it gets about $3 of NIH funding per woman living with the condition. So that's where we're starting from. I'm so thankful for a lot of the grassroots movements that have raised awareness about it. But one of the problems in approaching endometriosis is, as I was kind of thinking about implementation science and going to these D&I classes and learning, really wrestling about like evidence-based intervention, like what does that even mean in a field where our like first-line treatment's off-label? You can't point to one standard of care. There isn't a published usual care. Guidelines are a little bit of a joke because it really doesn't exist. This is all getting better, and like over the past, like ACOG in the past few weeks published some new guidance, and it's really coming along. So that makes me very excited. But that also kind of made me realize I'll probably spend a lot of my life in kind of hybrid type 1 land, and maybe by the end of my career, we'll have enough data to reach hybrid type 2, and maybe, probably not, but I would love to eventually be able to run a hybrid type 3 trial. Unlikely to ever get to, but for right now, I've just like accepted that I will be in this very gray space. So kind of coming back to a quote from the focus group, I like that I can share with other people, I like to hear what they say and to hear what has worked for them. You know what I mean? I've had that too. What did you do? How did you cope with that? What worked for you? And I think that would be helpful because I don't think that we have all the support that we need. So that kind of desire of what patients were needing and wanting, and the peer support and the time to talk and be listened to and listen to others really came with some of these other studies. And we kind of did what I call like the garbage disposal approach. So just kind of pulled anything that had a small effect size. So there's a few studies showing that group care for chronic pelvic pain is effective. So like, great, we'll take a group care approach. Then there's others that kind of that show that mindfulness interventions can improve quality of life, anxiety and depression, with pretty solid effect sizes, although the trials are very small. Physical therapy is probably one of the areas that has the best data globally, although hasn't been super well described in endometriosis, but can have a much more kind of perhaps a little bit bigger effect size. And then yoga studies are kind of all over the place in terms of size and their impact, but also probably have something in terms of impact, maybe even a lot based on some of the trials. So we just figure we would just bring together anything with a small effect size and then build it into a group care approach. So then this is where we put together an interdisciplinary team that I'll talk more about in a minute. We developed peer-empowered endometriosis pain support, or PEEPS, as an interdisciplinary and integrative group care program. So the overall kind of structure of it, it's an 8-week program. We meet for 2 hours a week, and the goal is to have about 6 to 10 participants at like per cohort, plus the facilitators. And then they also receive a participant binder with a printout of all of the materials that they're encouraged to bring with them each week. And then at the end of each session, we have kind of like a homework activity. There's some kind of self-reflection that kind of builds on the topic of the week and ties into the following week. So in the session flow is kind of 15 minutes of like an icebreaker, which is either kind of discussing the homework of the prior week or something to get people to know each other a little bit better. We have a 45-minute interactive education session or education time, a 10-minute transition break, and then do 45 minutes of yoga, and then leave some time at the end for wrap-up and surveys. The yoga intervention was developed by yoga instructors who are also pelvic floor PTs. I didn't realize that that's a common combination, that many pelvic floor PTs are also yoga instructors. So we were able to kind of build into the yoga session a lot of the different components that they might educate on during a pelvic floor PT session to make it a bit of a hybrid of yoga plus PT. So in terms of kind of thinking about like the timeline and the overview, this is kind of tied in based on the different, just like timing of the different grants, as well as what we've been doing. So in this, I'll talk about this part first, but so we kind of spent some time with the qualitative adaptation, and then launched the pilot just feasibility trial. And so I'll talk about the adaptation piece first. I was super fortunate to land at an institution that has lots of really people who are passionate about providing pelvic pain care, but no one knew each other. Kind of the typical academic silo, giant campus, everybody doing kind of work in their own silos. So it's so fun, kind of as I was starting back, I'd done residency here and then boomeranged after fellowship, to start meeting anybody and everybody who might be doing the work. Then Tracy Spitznagel is a pelvic floor PT. And she leads the women's health residency. So one of the things that has just been so instrumental was her investing in this and also saying, hey, like this is a great learning opportunity for my PT residents to get to learn about group care delivery and endometriosis. So over the years, we've now worked with, I think, 4 or 5 different classes of PT residents who've cycled through. On the PT and yoga side of things, we've had 3 different physical therapists who are also yoga instructors involved in the development. Sarah Boudet is a pain psychologist. They're sadly very rare, but she has been the person really leading the pain neuroscience education from that standpoint, and the synthesis of education from the like brain function side of things, and myself on the gynecology side, and then her research coordinators, Chioma and Kate. So a group at UCSF and the Center for Integrative Medicine had published these studies on centering CPP. As I was thinking about doing this, I kind of came across these papers, reached out, and they were so lovely in terms of sharing. They're like, hey, this is what we did. We did it as part of a trial and haven't continued it. But like, here's our curriculum. Here's what we did. And we were able to really look at like what people had done to have that as a starting point. So this is kind of the initial part. It's kind of funny now looking back at it because where we started is actually not really anywhere near where we were eventually going to end up, but it was so helpful to have a starting point. So the Centering CPP program kind of follows the Centering Pregnancy model, where it's once monthly sessions for about 9 months, 9 to 10 months. And they used, so the session format's fairly similar to what we did, although they weren't using yoga. That was something based on the PT's experience they felt was really important to build into the intervention so that we can really teach people how to do healthy movement in kind of a facilitated and safe environment. So these were the kind of 10 topics that they used, and then loosely how we combined it to kind of move from like what might be kind of mainstream at an integrative medicine center in San Francisco to make it like more appropriate and what would be expected in the Midwest. And we also decided to condense it to 8 sessions, somewhat arbitrarily. And then we really wanted to deliver it once a week. So it was an intensive intervention. Um, so that's kind of how we got to this. And the general kind of flow is understanding endometriosis, different types of strategies, and eventually it kind of got more focused kind of a little bit by specialty. But anyway, general topics in terms of symptom management, managing stress and kind of coping with pain, really understanding the brain's role in endometriosis and pain, sexual health, nutrition, resilience, and kind of self-help strategies, like what to do beyond PEEPS, and then wrap-up time. So that's kind of the general concept of kind of where we started, where we launched with the feasibility trial. Let's see. Somehow lost my. Okay. So after we kind of came up with this like general trajectory of what we thought we wanted the intervention to look like, we then took it to our departmental community advisory board. They were great to collaborate with us and give us feedback on design, concept, eligibility criteria, recruitment methods, compensation. There was feedback that we would have loved to have integrated, but we couldn't, like having childcare, providing meals, things like that, but was helpful to be able to integrate a lot of their feedback. Then from the community advisory board, we kind of met again and revised what we were going to do, and then moved to the community engagement studios. And this was a new process for me, but was also super fun to then engage with patients who recruited to participate to kind of ensure representation across a variety of different backgrounds, and also clinicians across the region, trying to get representation from academic, community, different specialties, nurse practitioner, physician, to get feedback. Oh, we also have people from FQHCs. It was so helpful to kind of think about what would this delivery look like, and we're able to get lots of feedback there. So then kind of in parallel to all of this, I guess I really should have put the consensus discussions first, because those started first. We just meet once a month over lunch, talk about things, make a plan, like what did we like about the curriculum? What did we think need to be changed? We each kind of go back to our literature, come back, and then ultimately, like PT ended up developing 2 sessions, I think pain psychology 3, and then 3, something like that. And then kind of at the end, did the community engagement studios as the final thing before launching. I discovered DNI, or actually one of my mentors was like, Whitney, what you're doing really sounds like there's like a whole field that does this. So by the time that we reached community engagement studios, had some DNI mentorship, and were able to start using some frameworks to bring into the adaptation process. So then looking at the pilot trial, so this ran from March 2022 to December 2024. We were aiming to have 40 participants, ended up having 33. This is just our recruitment diagram of kind of who we approached, what needed to happen. Based on the team's availability, there were certainly aspects that were not ideal in terms of it needed to be on the WashU campus. It needed to be Mondays from 4:30 to 6:30 p.m. So those were kind of things that we couldn't change because that's what worked for the facilitator team. But on the flip side, there were other benefits. So then we could do this on a shoestring budget with people really investing in patients and in the intervention, basically for free. So anyway, I think we could have reached more people for sure with a different time, different place, but we're definitely constrained. One of the things that's incredibly humbling to me is we recruited people who have pain approximately half of the time or more. And of these 33 participants, 82% attended greater than 6 sessions, and 33% attended all 8 sessions. And every time that I think about that, it just makes me tear up a bit because I just admire our patients so much who have gone through this really horrible trajectory, but then when given the opportunity and given support, really show up and invest so much in themselves and in each other. As we've now been running, I guess, 3 years and without really much money for like on my career development awards. And it's ended up being somewhat sustainable for us as a team because it's an educational opportunity for the pelvic floor PT residents. So in the fall, they shadow and go through a cohort to observe. In the spring, they teach. So that ends up meeting some requirements for them. They also get to really learn a lot about gynecology through the sessions taught by me, about pain psychology, and the sessions taught by Sarah, and learn a lot about facilitation. So it's a great opportunity for them. For us as clinicians, it's been providing care for people with chronic pain a lot in a traditional model can be really slow, and it can take a long time for people to be able to I don't know, to see improvement, meaningful improvement in patients' lives. Whereas with PEEPS being short and intense, a lot of times we get to see people just have this tremendous growth. And it's just so beautiful and inspiring. We've kind of grown to call it like PEEPS magic. It's like, I don't know how we measure it. I would love feedback on that. But kind of seeing people kind of come and then have these aha moments. So anyway, it's been this really kind of rewarding thing for us as facilitators. And it's also been the foundation of what will eventually be like an endometriosis and pelvic pain center as we've kind of slowly, like I would have loved to immediately like come in and have a center. But now we have those relationships, we do soft handoffs and care, kind of know what resources are out there. So it's kind of helped us do a bit of a soft launch in that. And then for us, we can stay if we want and do a free yoga class and give some time of forced mindfulness. So those are kind of been some of the soft things that have helped keep it running. In terms of the pilot outcomes, we had people who had endometriosis, but also a high rate of comorbid chronic overlapping pain conditions. Pelvic floor dysfunction was in about half of people. Migraines and irritable bowel syndrome were the other most common ones. It was an incredibly educated cohort. Academic campus, 4:30 to 6:30. Makes sense that in retrospect, that we would have recruited a lot of people who work kind of near the academic medical center. So unfortunately, like this is not the kind of racial demographics, and ethnicity isn't especially representative of our global patient population. It's about 60% white, 40% Black. Hispanic ethnicity is fairly representative of in this tiny cohort of the region, but unfortunately was not very racially representative. And then the other thing that probably is a little bit different than the more general population is in terms of thinking about stage of endometriosis. 80% of people have stage 1 and 2 endometriosis, and 20% have stage 3 to 4. The patients that we have the most access to are patients coming to our tertiary referral surgical practice. So it's understandable that it skews more towards people with higher stages, but was again another learning point for us in terms of figuring out how do we access people. In terms of what we use to evaluate it, from satisfaction with the intervention and some of the early implementation context, we use AIM, IM, and FIM questions, and we'd have them answer surveys at the end of each session, and then a global assessment that kind of looked at the program as a whole, as well as some of the intervention and delivery methods at the completion time point. And overall, people really liked it a little bit. Anyway, you're like, oh, I don't know. I asked them for candid feedback. Take it for what it's worth. Overall, it seemed like people liked it. Um, and then the things that were really exciting, I wasn't actually probably expecting to see a measurable improvement, was super excited to see that we were actually measuring impact in some of these validated patient-reported outcomes. So the Endometriosis Health Profile 30 or EHP 30 is one of the few, I think it's the only validated patient-reported outcome measure for people with endometriosis. And it's a composite score and then has these sub-scores. So we're seeing improvement in the composite score at completion and then more so at 6 months. And kind of that trend is pretty consistent across that things were improving at completion, but then continued improvement at 6 months. As I've talked to more people doing group interventions in the aftermath, this is really demonstrating that I felt a little bit surprised by these outcomes, but then realized that I shouldn't be surprised by these outcomes. And that's really what the objective of delivering a toolkit and building self-efficacy is. That yes, you give improvement, but that people then have tools to have continued improvement in the future. This is prelim. These numbers are almost certainly going to change as we need to go back and reanalyze some data, but at least the prelim was pretty exciting. Promise are the NIH kind of funded measures that show relative to national average patients. We saw kind of similar trends here whenever their measures, what higher number means more of what that is. So pain interference, higher number is bad, physical function, higher number is good. So we're kind of seeing those kind of same type of trajectory for the most part, slight improvement at completion and continued improvement at 6 months. This also kind of showed that it's important when assessing patients who are, so most all of our participants were 18 to roughly 45. Almost all are employed, many are very active. So perhaps a measure of the national population that their severe disability is can't get out of a chair or almost bedbound isn't going to be as responsive as something that's a measure that's designed for the patient population. Okay, so back to the design overview. So this kind of got us through the first round of adaptation, the pilot feasibility trial. This was promising. So kind of for perspective in terms of years, adaptation was 21, pilot was 22 to 24. Then over this next part in 2025, we spent most of the year kind of synthesizing data, digging into the different surveys, outcomes, and working on that adaptation process, and then relaunched with the next iteration in fall of 2025 for a pilot RCT. One of the things that was really unfortunate in terms of just grant funding cycles was that I had to publish the RCT on clinical trials before I had analyzed the KL2. I had the full follow-up data for the KL2 feasibility trial. So we could have powered this second trial, but it was too late. So anyway, it will continue to be a pilot, but that's one of the things that's a little bit sad. So in terms of thinking about this second round of adaptation, so we kind of analyzed the different AIM, IM, and FIM responses from those weekly surveys, the summative evaluation, as well as people were very kind to provide a lot of qualitative responses. One of the things that I found was that the different people who were analyzing it came back to me. They're like, Whitney, you are way too critical. There's only one person who would have been this critical. So that was kind of a note to myself of when I give feedback to myself, don't make it scathing for the future. So that was pretty funny. The patient feedback mine was the most critical of all. And then we were kind of looking at the CFR domains of innovation characteristics and characteristics of individuals. Then as we kind of went through that next year of, again, consensus meetings, we were able to bring a patient representative on board who had participated in the PEEPS intervention. So she was really part of this next round of adaptation and helping us figure out how to iteratively improve that. What I have in the kind of aqua square is kind of the things that were like, hey, this is core to the intervention. We don't want to change it. This is like what we think is really needs to stay for now. So we really like the format in terms of 2 hours for 8 weeks. The peer support came out as very, very important. Some people were like, hey, I would have liked more. The interdisciplinary nature, integrating the yoga and making the sessions interactive. So those were the things that we didn't want to change. And then when we were thinking about the adaptable periphery, there were some things that we really couldn't change in terms of time of day, place, providing childcare. It's like we just don't have the funding or the capacity to do that yet. Um, and then, but we were able to really overhaul the sessions. We had a session on nutrition. That one really was kind of missing the mark pretty consistently. Patients really valued. One of the groups actually had just kind of a spontaneous session where one of the participants was like, hey, I want to hear your story, and just like asked the other participants to share their story. And it just like ended up being one of the most beautiful sessions of all. So we kind of decreased some of the educational content to have a week just dedicated to sharing your story. We overhauled the pain neuroscience session because we got really valuable feedback both from our patient advocate as well as some of the feedback that some of the tone wasn't helpful. It could kind of be contributing to some of the dismissal. It could be hitting some of the notes that had made people feel dismissed in prior interactions. And then we were able to really hone the themes for each week based on seeing kind of what had landed, what hadn't landed, and being able to then more thoughtfully have the topics build based on what we'd experienced in terms of growth of maturity of groups, cohesion, what people were comfortable sharing and engaging with based on that built trust over time. We're also able to be more thoughtful in how we recruit. That has, at least so far, seemed like it has improved reach. We no longer have sessions of like mostly WashU kind of staff. Still some of that, but actually the majority of patients are now no longer coming from our MIGS practice, which I'm so happy for. And then we're also able to adapt the yoga more based on, for example, people really didn't like downward dog. So that was taken out. That was like came up as like negative. There was also kind of observations like some classes were too fast, some were too slow to kind of hit that Goldilocks spot of like what's appropriate movement for people with chronic pain. And then we're able to add more yoga props so that people were able to adapt more and make the yoga like fit people's bodies more so than people be kind of even grow more in that space to make the experience more comfortable for people. So the hybrid type 1 trial is going on right now. We kind of arbitrarily set the target enrollment for 60. As I said before, like 88 would have powered us for a 6-month outcome. We thankfully get to follow people up for 12 months. We've been able to add in focus groups to understand people's experience farther removed from the intervention. We've added more questions about intervention utilization. And then also built in the opportunity for activity tracking so we can start to understand some of the mechanisms that are driving these responses that we're seeing for people. Okay. I'll just go, this next part is much smaller and then I'm excited to go through questions. So in terms of the kind of the other piece, so now we kind of talked about like the end treatment. The other area that I'm really interested in improving is tackling the diagnostic barrier. So in a study that's co-led with Adam Kepich, who's a neuroscientist, we're using the whole concept that pain is experienced in the brain, but the signal's coming from the uterus and the pelvis. So it's got to be transmitted somewhere, some way through nerve endings, proteins, and neurotransmitters. So it's a closed circuit. If the brain can detect the pain through protein and neurotransmitter signals, we can find them in the blood. So this is a project funded by ARPA-H, and we've been we developed an app to be able to understand behavior better, to track patient behavioral metrics using kind of some traditional methods. And also he and his team have developed some mini games that more quantitatively track pain. And then doing proteomic discovery to be able to develop a risk score, with the idea being that instead of having to wait all of that time to find the subspecialty person, that we could address the care-seeking delay by, this is kind of what we talked about before, like the care-seeking delay and the healthcare-related delay, that we would be able to, from symptoms, get people to start tracking with the app to kind of identify what might be going on more quickly, and then be able to have a blood test that then would be able to get people into tailored treatment more quickly. And then eventually, I want to adapt the PEEPS intervention more so it could be more scalable to be able to give it perhaps through hybrid delivery in like higher resource settings where there's still an option for an in-person component that I think is so powerful, but then also mobile delivery so it can be scalable to people not around the academic ivory tower. So in terms of my soapbox thoughts, I would just challenge each of you to help combat period stigma and then normalize and help normalize discussions about menstruation, reproductive, and just general womb health. Half people have uteruses and things can go wrong. So also, if someone in your life's periods are causing them to miss school, work, life events, please encourage them to seek help. That's not normal. And then I'm always happy to come into spaces that isn't typical of, yeah, where women's health is being recognized as important because we end up being half the population. Team science is a blast, and I absolutely love the teams that I work with. And I'm just so thankful for just my clinical partners who are amazing at referring patients and pitching our research, and our research teams that make research fun every single day. And then I have the best mentorship team that has just been so supportive in terms of helping me figure out how to be a surgeon and a researcher and figure out implementation science and build a program. So thankful for each and every one of them. And thank you, Anna, for being here. And then thanks to funders, and there's my info. But I would love, let me jump out of this so I can see the chat, if that's okay. Okay. Thank you all for being here. Let me see.
This was wonderful. Kara, I let you continue with the moderation activity, but just wanted to thank you for the very incredible journey that you shared with us, how you went from the problem, and it was heartbreaking to see how funding is disproportionate for this type of challenge. And I love to hear that there is some improvement. My main question for you, if I may start, and then Kara, please help navigate. There were many wonderful questions in the chat. When I think about hybrid designs,
Mhm.
I always get challenged because, I appreciate that by some standards, there is not enough evidence to talk about evidence-based interventions. But by other standards, these are pretty established techniques that can be used to address, pain or other things. So I think I could argue that you have a whole array of evidence-based options that could be tested in a hybrid 3 setting because the main issue is our main issue is not having those being implemented consistently. Although I hear that there are perhaps needs for improved methods for treatment, etc. But I think that we know certain things that they are just not being delivered in a timely or equitable way. So I don't know if you have any reaction to that, but I'm just kind of trying to push in the direction, and especially as I'm thinking about Kara's dissertation work as well, that we have an opportunity here in the hybrid 3 space.
Oh, I love it. That will make me so happy. Yeah, I think one of the things yes, I think one of the things that's hard is, yes, there are medications that work. And in a lot of ways, there's a lot of data. So I see where you're like, I see I totally see where you're coming from. In terms of one of the other studies that we're thinking about right now is we don't have data, like let's say someone comes in and is like, birth control hasn't worked. We actually don't have data to say what's the next best thing, which is, you're like, how do we not have that data? It's like, there's lots of, hey, this is what I've seen work for people. So there's things that work, and I think there's more and more understanding in kind of niche practices of how to manage pain. I just haven't really seen it get into the literature well. So I think that there are things that work. We just don't have a lot of efficacy trials or like head-to-head trials. Yeah.
Yeah, no,
Super curious.
I love that, and I think it's kind of almost like and like there are
Yeah.
certain things that there's a certain level of evidence that we can perhaps classify differently. And I'm thinking about Ross Brunson's paper about different kinds of evidence that we have for action, and makes me think of that. So I will step back and allow others. There were some really excellent questions in the chat. I was excited.
Yeah. Dr. Nasser, I know you had a couple or a couple questions in the chat. Do you want to me to read them out loud, or do you want to unmute and ask them yourself?
Sure, sure. Hey, thanks, Dr. Ross, for this talk. It was really fascinating. I mean, I had did an MPH that was kind of based in community-based research and did some focus groups with people in the Marshallese community and in Seattle where I was training, and so it's really important to like you reach out to these communities that we're working with and like get their feedback on things. So I was loving to see that integration of that feedback. My first question. Was asking about like managing misinformation in like the peer-to-peer groups because I regrettably spend too much time on social media, and I know there's a lot of misinformation, especially in endometriosis space that goes around out there. And I think there was a study that kind of sought to quantify that. So what were some of your strategies to help address that in the groups?
Yeah. I think just kind of pointing out, it's like, okay, like when misinformation came up, kind of saying, yeah, I've heard that as well, and kind of redirecting a bit and saying, yes, that's a common misconception. But when we actually have like fairly good data in this space, or that may be true for some people, but isn't like a pervasive experience. So we're able to kind of redirect or just kind of sometimes address it directly.
Yeah, and because I guess my follow-up question to that is like in the it's a more logistical question, but are the moderators to those groups just the PTs basically the are those the
Yeah,
main
so
people?
for this particular group, so I moderate most of the sessions, and
Oh,
then Sarah Boudet's the PhD pain psychologist. So we end up kind of moderating most of the sessions.
oh, great.
Yeah, that's definitely one of the things where it's like we have kind of clinicians moderating, which
That's
makes it
helpful.
kind of easy for kind of that to say to kind of combat misinformation. But that's one of the things that like as we think about scaling, um, that we'll have to address. Appreciate that question.
Great. There's another question. Noi, I apologize if I mispronounced your name. Do you want to unmute and ask your question, or would you like me to ask?
Sure, I can ask. I'm Noe Pimpasan Brady. I'm an associate professor in the Department of Psychology at the University of Colorado School of Medicine, so part of like Russ's D&I group. Whitney, this was great, or Dr. Russ is great, and I really appreciated just hearing about just endometriosis in general. I co-founded and I co-direct our multidisciplinary program for polycystic ovary syndrome. So very similar in terms of like diagnostic background and long delays in medical treatment, similar to endometriosis. But we have also established a CAB as part of our program. And I think we always kind of, my first question was, what were the strategies you applied to maintain continued engagement of your CAB in design and adaptation? I know CABs can be kind of tricky to maintain if you don't offer, certainly a monetary benefit for their time and expertise. So that was my first question.
Yeah. So in terms of the CAB, it's funded kind of through our department. I think this was one of the first GYN studies that this particular CAB supported.
Mhm.
So We engaged a little bit kind of in the design process, but it was definitely not a co-design type of situation. So the CAB members are compensated for every session they attend. And that compensation, I think, funds through some of the MFN's funding as well as the department. So I would say that kind of engagement with the CAB was an early part, but wasn't longitudinal. What we then found to be more helpful was embedding patient part like our patient representative, and I think we'll go that route in the future. And then we had her kind of for every session she attended, she was compensated like per hour. When we asked her to kind of give feedback, we just asked her to log her hours and just compensated her by the hour.
Yeah, that's great. Great, thank you. And I guess I'll ask my other question while I'm on here. I was also curious. I know you have focused on your presentation was focused on really the early work of like adapting, feasibility, and then trialing your groups. But I'm curious if you've yet considered sustainability strategies for your PEEPS group models, because I think we all know, I think that, patients love multidisciplinary care for these complex groups, but they're not so great for hospital clinic reimbursement. And I appreciated your slide at the end about kind of your next steps and thinking about how to integrate that app into clinical care delivery and trying to really test that hybrid approach. And I'm curious if there are other maybe sustainability strategies you've considered.
Yeah, I mean, one of the things that I think that just because of like the educational benefit at WashU, we will probably be able to sustain this off of a trial. But I think that's a pretty low bar. Just because, yeah, for a variety of reasons. Because one of the things is that I feel so bad for our coordinators because they, after participating in PEEPS, like making the randomization calls now, like ends up being kind of the worst part of their year. There's a lot of tears. So we, like after completion of the follow-up, we plan to do just like invite anybody who is randomized to control to be able to come back and do some sessions. And then the next part of what we want to do, I think it'll still be kind of, since this pilot still won't be kind of definitively testing efficacy, making it a hybrid where the first and last sessions are in person so that people can kind of have that face-to-face comfort with each other and then get that peer support, and then doing most on like remote delivery. So I think that that'll help us be able to decrease the amount of time that patients are driving to us and also decrease facilitator burden a bit. And then I'm really intrigued by the concept of like training up patient navigators to be able to facilitate. And I think that we likely need to be able to do that. Like in the next phase, we'll be really kind of building up like the fidelity piece and thinking about how are we going to deliver this not by the same facilitators who like built it and teached it and all of the different things facilitating every single week. So some of it's going to be like really building up a curriculum, training people. And then I think for a lot of, since it's so interactive, I think at first we'll probably need to have like me on call and like available. So if there's questions that the facilitator can't field, I can pop in. And then as we kind of, I imagine kind of reaching saturation to some point where most of the questions are then compiled in a place that a patient navigator or one of our team members could then facilitate the groups. So those are some of the next steps in terms of thinking about how can we get it delivered by people outside of academia.
Great, thank you. This is great.
Well, we have just a little bit less than a minute left, but I just want to take a moment to say thank you so much, Dr. Ross, for presenting today. I will say I'm a little biased because my dissertation work kind of revolves around this intersection, but I am so glad that you were able to share your work, and I am so excited for the next iteration and the future directions of this work as well.
Thank you. I really appreciate y'all having me, and I'm so happy that you're in this space.
Great. Thanks, guys. I hope you have a wonderful Monday. Great rest of the week. And I will be posting the recording on our website in probably today. So have a great day, guys.
Thanks,
Thank
everyone.
you.
Bye.
Thank you so much, Dr. Ross. Bye bye.
Bye-bye. Thank you.